Today, what I'm going to talk about are some updates in breast cancer staging. For those in oncology, for your Commission on Cancer accreditation, they always like for us to talk about new updates in staging, and so that's a little bit of what I'm going to do today. And I'm also going to talk about a few things with management. So, goals and objectives of today. I'm going to go over the 8th edition AJCC staging guidelines for breast cancer that were recently updated. I'm going to talk about the current role of immunotherapy in treating breast cancer and what some future directions may be. And I'm also going to talk, and these are kind of disparate issues in breast cancer, but I'm going to try to tie them all together. But I'm going to talk about the role of genetic counseling in some of our breast cancer patients and when to consider that in people that might be at risk for breast cancer but not yet diagnosed. Throughout my talk, I'm going to be highlighting the role of neoadjuvant therapy and neoadjuvant clinical trials in our understanding of breast cancer biology and response. And at the very end, I'm going to talk about a few ongoing clinical trials that we have open for breast cancer patients at University of Kentucky right now. I'm a huge proponent of neoadjuvant therapy, and that slide is not quite coming across the way I was, but I really hate it when people do talks and they're just like throwing out acronyms and assuming everybody knows what it means and all these statistical things I'm going to talk about. So just to go over for people that may not know, when I say neoadjuvant, I mean any type of systemic therapy, medical therapy, that is given to a patient prior to surgical resection of that breast cancer. So that might be chemotherapy, but it might also be endocrine therapy, estrogen blocking therapy, that's given to shrink down that cancer before a lumpectomy or mastectomy. When I talk about adjuvant therapy, I'm talking about therapy given after surgical resection. Statistics are kind of but I think we need to talk about them, especially in the oncology world. One thing to know is ORR, overall response rate. This is something I'm really going to hammer home when we're talking about immunotherapy. That means if somebody has a complete response, their cancer completely disappears, or a partial response, it just shrinks. Another term you'll hear us toss out a lot is path-CR, or pathologic complete response rate. The pathologist cannot find any evidence of tumor cells, of breast cancer cells, in the specimen. That is always our goal. Path-CR is associated with a better disease-free and overall survival. Stable disease and progressive disease, pretty self-explanatory. That's when we're talking about our stage 4 patients. OS is overall survival, and I think you can argue probably the only statistic that patients really care about, and maybe what we should focus on a little bit more. And that's just the duration of time that a patient survives after a diagnosis, no matter whether their ultimate demise was from breast cancer or a car wreck or an MI. They all count for overall survival. Progression-free survival, so that's like for your patient with stage 4 metastatic disease, the duration of time that they live with cancer with no evidence of progression. Disease-free survival, that's more for like your early stage breast cancer. They've gone through their surgery, their adjuvant therapy, their radiation. And so you'll hear a lot in adjuvant clinical trials that what they're monitoring, what their primary objective is what is our 3-year or 5-year disease-free survival rate. And that's the length of time that after the completion of their cancer treatment that they survive without any evidence of a recurrence. BCSS is going to come up in another graph that I talk about. That is breast cancer specific survival. And that's in a study the percentage of people who have not died from that specific disease, breast cancer, in a defined period of time. So if you die of another unrelated cause, car wreck, heart attack, you're not being counted in that measurement. So with that, let's talk about 8th edition AJCC. Why did they change it? So the initial AJCC staging, TNM staging, which is what we're kind of all familiar with, was established in 1977. And that's where T is the size and the extent of your primary tumor. N is the number of nodes that are involved and the location of those lymph nodes. And M is the presence or absence of distant metastatic disease. But for many, many years, decades really, within a given TNM stage, there were huge biologic differences within the behavior of that breast cancer, and that had a huge influence on prognosis. When we talk about breast cancer, we always talk about the expression of 3 different proteins, and those are the estrogen receptor, the progesterone receptor, and the HER2 receptor, which stands for human epidermal growth factor 2 receptor. We'll just say HER2 from now on. the presence or absence of those three receptors is very important to our treatment choices and prognosis. We also talk about the grade of the tumor. What does it look like under the microscope? And that's something we get from our pathologist. Started to realize that really, excluding some very rare types of breast cancer like adenoid cystic or metaplastic, we have 4 distinct molecular subtypes of breast cancer. And this would be luminal A. These are your strongly estrogen receptor positive, very estrogen dependent, slow growing breast cancers. Luminal B, which are estrogen receptor positive, but they're a little bit more aggressive. They have a higher mitotic rate. They could be HER2 positive or negative. Something called HER2 enriched, which are your estrogen receptor negative, HER2 positive breast cancers. Aggressive, but we have good targeted therapies for those now with drugs like trastuzumab and pertuzumab. And basal, which is also called triple negative. That's your ER negative. The way I explain it to patients, we're looking at gene expression in your breast cancer cells. There are many of these multi-gene panels. There's Oncotype, there's PAM50, there's Mammaprint. Oncotype DX is the one we use most often. It looks at 21 different genes in breast cancer cells that can be turned on or off. And depending on the pattern of which ones are on and off, it is both prognostic, how is that woman going to do long term, what is her recurrence risk, but also predictive, whether she would have benefit of chemotherapy or not. So we started using that in the ER positive, HER2 negative, no negative tumors, and that was based on data from the NSABP B14 and B20 trials. And more recently in 2018, the Taylor X trial was published in New England Journal, and that showed that basically with people that had an Oncotype score of 25 or less, they didn't have any benefit of chemotherapy. They did very well long-term without it. And for scores 26 and higher, they had an indication of chemotherapy. So we were already using this to determine prognosis with our early-stage breast cancers and determine the relative benefit of adjuvant chemotherapy after lumpectomy or mastectomy. So why did they even bother changing it? Like we talked about, the prognostic was changing. They looked at over 200,000 patients from the National Cancer Database, and these were, for the most part, patients who were treated appropriately. That meant that they got the drug trastuzumab or Herceptin if they were HER2 positive breast cancers, which FDA approved in 1998. And actually, Dr. Ramond, who was a medical oncologist who trained me at University of Kentucky, was a huge part of those trials that got trastuzumab approved. So these were not people who did not receive chemotherapy, did not receive the appropriate treatment. And they confirmed that their prognosis varied widely within the TNM groups. It led to identification of 170 different prognostic groups, which we are not going to go through. But basically, they used the basic TNM, ER, PR, and HER2 status. And they also used Oncotype DX and some of these multi-gene panels as stage modifiers. This started to be used by our cancer registrars in January 2018. And that changed the stage for approximately 40% of our patients. For example, I saw a patient a couple weeks ago who had a T2N1, normally stage 2B cancer, but because she had a low Oncotype score, she was ER positive, HER2 negative, that got restaged as a 1B. So this is based on a study published in Oncology 2017 from the California Cancer Registry, where they applied some of these same changes. So I thought what we would do is kind of look at stage 2B group here, T2N1. So here is the N in each group. So these are thousands of patients, like 43,000. This is also looking at our 5-year breast cancer specific survival. Same anatomic stage. Our ER, this is hormone receptor, ER positive, PR positive, HER2 negative group. They have a 93% chance of breast cancer specific, breast cancer free survival at 5 years. But look down here at our HER2 positive, ER estrogen receptor negative group. For the same stage, we're only looking at 84% free of breast cancer at 5 years. And when we get to our triple negative breast cancer, 76%. So higher and higher risk of recurrence as we're going along. This is kind of the same data from that same study, but shown in a graphical form. So this is, so basically they get points for if you're ER negative, that's 1 point of badness, right? If you're HER2 negative, that's also a point that's bad because we have such good drugs to target the HER2 receptor. And if you get a point if you're grade 3. So, and it's really hard to see that. But the good line is the blue line that didn't have any points, and that's on the top of the group. This brown line, this is your triple negative breast cancer, highly aggressive, high grade, ER negative, HER2 negative. And what you can see is for the stage 1, which is this graph right here, and this goes out to about 8 years, about 100 months. So they're all doing really well. You're talking about 95% survival for all of the groups. But then you get down, say like here, our 2Bs and our 3As. You really see that, and this is your survival probability, again, breast cancer specific survival. The triple negative group has fallen away. They are not doing as well. They're 50% over breast cancer specific survival is basically about, I think that's about 5 years, but it's kind of hard to tell. But basically everybody else is doing pretty well at 8 years, but you've only got about 40% of your triple negatives to about 50% of your triple negatives still doing well at that time. So, like I said, for small tumors, everybody's doing pretty well. The bigger the tumor that gets, the more those biologic differences, those molecular and genomic differences start to make an effect. So this is from the same study again, but looking at stage 4 patients. So these are all patients who have distant metastatic disease. Over here is a graph of overall survival. Over here is a graph of breast cancer specific survival. Look at these two graphs. They're almost superimposable. What does that mean? That means that most patients with stage 4 breast cancer are going to be dying from breast cancer and not from other causes. But again, look at the difference. So this would be your ER positive, HER2 positive, lower grade breast cancers. Their survival, basically half of them are still going to be alive at about 5 years. So you've got a median overall survival of about 5 years here. And this again goes out to about 8 years. But our triple negative breast cancers, their median overall survival is only about 18 months or so. So really it's about 1.5 years to 2 years for a stage 4 triple negative breast cancer is a median overall survival. And for a lower grade cancer, it's much longer. So, and one thing I would just like to point out with that is that, lots of times people not in oncology will ask us, well, what is the prognosis for this patient? She has stage 4 breast cancer. How long do you think she really has? And I say, that really depends on the type of breast cancer that she has. It could be 1.5 years to 2 years for a triple negative breast cancer with treatment. It could be many more years than that. So to talk a little bit more about triple negative breast cancer, which is kind of, our worst, poorest prognosis type of breast cancer. So these are cancers that lack all 3 of those receptors. They don't have the estrogen receptor, progesterone receptor, or the HER2 receptor. It's about 10 to 20% of breast cancers total, generally found in younger women. So these will be like your women that might be in their late 20s to 30s diagnosed. Higher prevalence in African American and Hispanic women, and the worst prognosis with a median survival of only about 17 months. And that's for stage 4 disease. So, but, and this kind of leads into the second part of my talk, these cancers tend to be associated more with what we call tumor-infiltrating lymphocytes and PD-L1 or programmed death ligand 1 expression. So now I'm going to talk about immunotherapy in breast cancer, which kind of leads into that. And a lot of these slides I did get from a presentation at the San Antonio Breast Cancer Symposium that Dr. Adams gave last year. You'll notice that a lot of this data has just come out in the last couple of years. So TILs are tumor-infiltrating lymphocytes. And people started to realize that when you saw that in pathology, that was a predictive biomarker for a chemotherapy response. So these are based on studies that were done with neoadjuvant treatment. So all of these women got neoadjuvant before surgery chemotherapy. And then they're looking at their path CR rate down here. So it's about 3,000 patients. They found that the high TILs, more tumor-infiltrating lymphocytes, more frequently in triple-negative breast cancers than in those luminal cancers, those strongly ER-positive cancers. And that the expression of TILs was linked to increased path CR rates in all subtypes. The high TILs expression was associated with better overall survival for triple-negative breast cancer and HER2-positive breast cancer. If we look over here, so again, these are patients who are all treated with neoadjuvant chemotherapy before surgery. The blue bars, we'll just look at those. Those are people that have high TILs or tumor-infiltrating lymphocyte expression. So these are really just, basically our T lymphocytes that you can see infiltrating through your breast cancer cells under the microscope. If you look at all patients lumped in together, those that had high TILs expression had a 44% path CR rate at time of surgery. So in 44% of those patients that you gave chemotherapy to before surgical resection, they had no evidence of tumor at the time of pathology review. So that's incredible. That's why I love neoadjuvant, because lots of times when we're treating people with chemotherapy or medicines after surgery and the patient says, how do you know that this is doing any good? And I have to say, I can show you the studies that if I didn't give you chemo, you wouldn't do as well based on studies in the past. But if I'm giving a woman, and again, we don't do this for tiny tumors, but for big breast cancers, really aggressive breast cancers, if I'm giving a woman chemotherapy or targeted therapy or endocrine therapy before she goes to surgery, well, I'm doing a breast exam every 2 or 3 weeks. I'm measuring it. I can literally see it changing myself, and we usually do follow-up breast imaging about halfway through, so that if we're not having a good response, we switch to another treatment. If we see that we are having a good response, then we keep going, and we are always shooting for a pathologic complete response. If you look down here at the triple negatives, the ones that had the high TILs expression, which of course they're more likely to have high TILs expression, they have a 50% pathologic complete response rate. And when they have that, when we get pathologic complete response, we have a better disease-free and overall survival. So I'm going to talk a little bit about the PD-1 and PD-L1 pathway. You've probably seen ads for immunotherapy drugs, maybe in your office, or maybe on TV, Opdivo, Keytruda. These are PD-L1 inhibitors that are used to treat a lot of different types of cancers. Melanomas, lung cancers, renal cell carcinomas. They've kind of been the big thing, and they're being advertised like crazy. So how do they work? So here is our little T cell lymphocyte, and we can imagine this little T cell is living out, hanging out, mixed in with the triple-negative breast cancer. It has activating receptors and it has inhibitory receptors. So as it's living there with the triple-negative breast cancer, PD-1 and PD-L1 interact, and they inhibit the T cell immune response. So that basically the triple-negative breast cancer is saying, hey, I'm okay, don't get stirred up about me, I'm just here, don't have to worry about me. But if we can block that response by blocking the PD-1 and PD-L1 pathway, we can activate that T lymphocyte, and then it's like it wakes up and it realizes, oh, this is a bad triple-negative breast cancer around me, and I'm going to attack it. So that's what we're trying to do. So this is a key checkpoint in immune response regulation. And like I said, tumors exploit this. Breast cancers exploit this to keep growing and invade the immune response. Other things I want to, so it's mostly in your infiltrating immune cells. So this is like in your lymphocytes. So if you have high TILs, you're going to have high PD-1 and PD-L1, and it's highest in triple-negative breast cancer. So this is just kind of going through some of the initial studies that were done, and notice that they are all published in 2018, so this is brand new, that led to the first approval of an immunotherapy drug in the metastatic triple-negative breast cancer setting. So here's some, pembrolizumab is Keytruda, if you've ever seen that. Atezolizumab is Tecentriq. Prior to this, it was approved in urothelial cancers and lung cancers. And then this trial is looking at atezolizumab with nab-paclitaxel, which is a Abraxane and albumin-bound paclitaxel traditional chemotherapy drug. So these are mostly phase 1, phase 2 trials. And so what I want to point out here is that PD-L1 expression makes a difference, and when you use these drugs makes a difference. So, for example, this study right here, using pembrolizumab, single agent, no chemotherapy. These are for metastatic triple-negative breast cancers. This was PD-L1 positive, so they all had PD-L1 expression in their tumor, and they had all been untreated. It was their first line of treatment for that metastatic disease. They had an ORR, overall response rate, of 21%. So what does that mean? That means basically 1 out of 5 patients responded. So awesome, but not so awesome for the 80% that didn't respond, right? And they had a median overall survival of about 18 months, which, as I said before, their median overall survival for metastatic triple-negative breast cancer is about 1.5 to 2 years. So this next study, these patients were unselected for, they could have had, 3 or 4 lines of chemotherapy. They might be PD-L1 expressors or not. They only had an overall response rate of 5.3% and a median overall survival of 9 months. The next study down, atezolizumab, unselected, and then a PD-L1 positive subpopulation. In their unselected patients that could be PD-L1 positive or negative, they only had a response rate of 10%. But when you select out, just like in this previous trial, the PD-L1 positive patients, you get a response rate of 19%. And you can see the differences in overall survival there, that it made much more of a difference, and they did much better if you use this as first-line treatment rather than using it after multiple lines of chemotherapy. And these are patients that are triple negative, so they're not going to respond to endocrine therapy. So it's basically chemotherapy, targeted therapy, immunotherapy, but you're not going to be able to use your estrogen-blocking drugs. So, and then this small trial that was basically atezolizumab with nab-paclitaxel or Abraxane, 50% of these patients were PD-L1 positive. They found an overall response rate that was much better, but they also had chemo, of 39%, 54% when they were used in the first line, with a median overall survival of 14.7 months. This is the trial published in New England Journal last year that got our first immunotherapy drug for triple-negative breast cancer approved. This is called the Impassion 130 trial, and it was published in New England Journal of Medicine, and the data released at San Antonio Breast Cancer Symposium last December. So this is pretty new. And this got atezolizumab approved for the treatment of metastatic triple-negative breast cancer in March 2019. And that was our first immunotherapy drug we had. So this is the graph of their overall survival for their PD-L1 positive cohort. For the group that got basically placebo with the Abraxane chemotherapy backbone, they had a median overall survival of 15.5 months. But for the group that got the immunotherapy drug of atezolizumab with Abraxane, they had a median overall survival of 25 months. And that was both a statistically and clinically significant difference in median overall survival here. So this was approved first line in combination with nab-paclitaxel for PD-L1 positive patients. So I'm just going to switch for people that are not in oncology but might be working in ER as hospitalist or in your clinic. These immunotherapy drugs have a very different side effect profile than chemotherapy. So we're not seeing the nausea, vomiting, alopecia, cytopenias that you see with traditional chemotherapy. What you can see, if you think about it, is basically the consequence of your immune system being overactivated. So you can see bad diarrhea that looks like a Crohn's disease or an ulcerative colitis patient. You can see all kinds of strange endocrine abnormalities. It can actually cause something that's almost like panhypopid, so panhypopituitarism. It can cause hypothyroidism. It can cause basically like an autoimmune immune-mediated pneumonitis, which I have seen and actually can be pretty scary and look just like lymphangitic spread of cancer on a CT scan, so that can be confusing. It can also cause an immune-mediated hepatitis and nephritis. I have seen both of those things happen. Most always manageable by steroids, and that is how we manage it. So we put them on high-dose solumedrol or prednisone to get things under control. If it's a mild thing, we sometimes keep going. If it's really severe, we stop. And we don't do immunotherapy again. In the case of GI immune-mediated toxicity, it can get very severe. So, and to the point where even steroids aren't enough and you have to do infliximab, which is basically like Remicade, right, that you would do for your GI Crohn's patients. So, but most of the time, managed with steroids, things like hypothyroidism that can occur from an immune-mediated thyroiditis, we can manage that with medications. So different side effect profile and basically low threshold to suspect that and to put somebody on steroids and get your oncologist involved if they come in with one of those problems. So these are active phase 3 trials of immunotherapy drugs, generally with a chemotherapy background, that are going on in advanced or metastatic stage 4 triple-negative breast cancer right now. These are ongoing studies of adjuvant chemotherapy with immunotherapy after surgery, after lumpectomy or mastectomy. And these are ongoing phase 3 neoadjuvant triple-negative breast cancers where we're giving immunotherapy along with the chemotherapy backbone before that woman goes on to lumpectomy or mastectomy. So these are patients who are curable. And we're basically seeing, can we get a better pathologic complete response rate? Can we do better long-term by incorporating immunotherapy along with our chemotherapy treatment in these patients? So that kind of switches gears, and then I'm going to talk about genetic counseling and testing in breast cancer, which is important for triple-negative in particular. But I'm going to talk about which patients with cancer, so cancer patients, and this is following NCCN or National Comprehensive Cancer Network guidelines, should you think about referring to a genetic counselor? NCCN guidelines would say all patients with ovarian cancer should be referred to a genetic counselor. A new recommendation in just the last couple of years was to refer all patients with pancreatic cancer to a genetic counselor, and some of the reasoning behind this is that about 2 to 5%, which granted is not a lot, of pancreatic adenocarcinoma patients will have a BRCA mutation, but a lot of the problem with pancreatic cancer is that our prognosis is pretty grim. If we would like to identify something that we could potentially screen their children for later, something like a BRCA mutation that would affect their breast and ovarian cancer screening, we want to try to get those people into the genetic counselor and get testing done as soon as we can. Metastatic prostate cancer, especially at young ages, can also be associated with BRCA mutations and other mutations, and that's a new NCCN recommendation in the last few years, is to offer all of those patients genetic counseling referral. Any breast cancer prior to age 50. So if you have a woman with breast cancer diagnosed at 49, you should refer her to a genetic counselor or at least talk to her about it. You have a woman that's under age 45, for sure. Sometimes in that 45 to 50 range, it's hard to get insurance to pay for it. Generally, under 45, it's not an issue. You get a really young patient in the 20s or 30s, you're not going to have a problem. If you have a man with breast cancer, that is more associated with the BRCA mutation, and you should consider referring that patient. And any triple-negative breast cancer prior to age 60, and any woman who has had 2 separate breast cancers. So which of your patients who have not been diagnosed with cancer yet, but you might be seeing in a primary care clinic or something, should you think about also referring to a genetic counselor? This could be somebody who has first, which is like your parents, your siblings, your children, or second degree is like grandparents, aunts and uncles, and your grandchildren. If you have first or second degree relatives who had breast cancer at age 45 or younger, men with breast cancer, ovarian cancer, pancreatic cancer, metastatic prostate cancer, or if they have 2 or more close blood relatives, which is basically the first and second degree, but also expanding out to third degree, like your cousins, great aunts, great uncles, with breast or prostate cancer at any age. So if you have one of those people that, comes in, like, my mom had breast cancer in her 40s, and my aunt had breast cancer, and my grandmother had breast cancer, that should start to raise some red flags that there's something going on. But remember that prostate and pancreatic cancer can also be associated with BRCA mutations, and there's a few other deleterious pathogenic mutations associated, germline mutations associated with breast cancer risk that you should be aware of too. So why should you refer them to a genetic counselor instead of just doing the test yourself? So the Myriad rep or the Invitae rep or the Ambry Genetics rep will come by to your office and be like, you don't need a genetic counselor, just do a blood or saliva sample and send it off and you'll get your results back. Because that can open a can of worms you don't want to deal with. That's why. The genetic counselors can offer pre- and post-test counseling for your patient, and kind of like what I've always been taught in medicine, and I always try to teach the people that I'm teaching, is that you don't order a test unless you know what you're going to do with the results, positive, negative, or in between. You better know that before you order that test. Genetic counselors can help the patient if something bad is identified, inform family members. Sometimes you'll come across somebody that says, I haven't talked to my dad for 20 years and we're not on good terms, but I guess I need to inform him of this. They will help them do that. They can direct them towards research studies and support groups. Some of these kind of more rare genetic mutations that we know are deleterious, and some that we don't really know if they're deleterious or not, they can put them in touch with these research studies that are going to follow these people over time and see what happens to them over time. And also new data comes available all the time. So multi-gene panels are generally best. So we used to just kind of test for BRCA1, BRCA2 gene mutations several years ago, but just these multi-gene panels, multi-gene panels will include multiple different genes that can be associated with cancer risk, and the ones that I've listed here, BARD, CDH1, CHEK2, NBN, PALB2, RAD51, and TP53, those are just the ones I've identified in my breast cancer patients in the past few years. So there are, tons of others, and those are, in addition, for example, CDH1 is associated with lobular breast cancer and gastric cancer. NBN can be associated with breast cancers, but also renal cell carcinomas, I believe. PALB2 is a breast cancer risk gene that is almost as bad as BRCA1 and BRCA2, and TP53 is associated with Lee-Fraumeni syndrome. So the genetic counselor can also help the patient understand their insurance coverage and what their cost for this test may be out of pocket. They can also deal with what I call the dreaded VUS. That's called a variant of unknown significance. That's when you come back with a mutation in a gene and you're like, we don't really know if this is bad, good, or just there. Is it just like brown eyes versus green eyes, or is this actually going to turn out to be something we find out bad things about down the road? And that's where getting them into those research studies and follow-up is important. The genetic counselors can also help them understand the false reassurance of a negative test. So you have that woman who comes in, she's got breast cancer, she's got a strong family history of breast and pancreatic cancer, and you do your genetic testing and it comes back negative. Does that mean that there is not a hereditary mutation involved? No, it just means that maybe there is something there we haven't identified yet. So why should you test? Obviously, if you have a woman that has breast cancer, she has a BRCA mutation, that puts her at higher risk of ovarian cancer. Patients who have P53 mutations or Lee-Fraumeni syndrome have higher risk of breast cancer at very young ages, and then later risk of sarcoma. It can help their family members get early screening. So if you identify that in a young woman, she can opt for a risk-reducing bilateral mastectomy, risk-reducing salpingo-oophorectomy. If they're not ready to have a prophylactic surgery, though, we do have high-risk screening protocols that alternate mammography with a high-risk screening breast MRI that can start at age 30 or even 25 in certain cases. And if you identify your deleterious gene mutation, you will get insurance to pay for it, which is also an issue. Also, for BRCA-positive male patients, we start prostate cancer screening at age 45. And that's clear because they get metastatic disease at earlier ages. Also, some of these results can guide our treatment for a current cancer. For example, we have these drugs called PARP inhibitors, or olaparib and talazoparib. These are oral drugs that basically are used just for stage 4 breast cancer patients who have a BRCA mutation. They're also used in the ovarian cancer world. And also, to guide prophylactic surgery as above, if you are identified to have one of these mutations, you have an early stage breast cancer that could be easily treated with a lumpectomy, that might be a real medical reason that you should get a bilateral mastectomy, although we have a lot of women getting bilateral mastectomies now who don't actually need that and are getting more aggressive surgeries than they need. And then I talked about Lee-Fraumeni syndrome, very rare, but if you identify that, and we have seen this happen, a young woman, her early 20s, gets breast cancer, treated the usual way, surgery, chemotherapy, and radiation, and then in her late 20s, she's got a radiation-induced sarcoma. That's a patient you should avoid radiation in, and it's important to know that up front. So I've just included some information here. We do have 3 licensed genetic counselors that specialize in cancer genetics at Markey, and we have telegenetics available, which Dr. Modi and oncologists are using here. It's offered at all of our outreach sites. They have appointments on Wednesdays. This is basically just teleconferencing. And all of the information is on the UK SharePoint site, and I think Jessica has given some out as well here too. And this, if you're doing your COC accreditation, fulfills your standard for genetic counseling. And this is just some information on how to refer. Justine Pekarsky is one of our genetic counselors, and Amy Stevens, who I think is here somewhere, is your contact person. So, and then I'm just going to briefly touch on some clinical trials that we have open at UK. So, the Alliance 1131 trial is a phase 3 trial of platinum-based chemotherapy versus capecitabine, which is an oral chemotherapy drug, in patients who had residual triple-negative breast cancer following neoadjuvant chemotherapy. So again, the importance of neoadjuvant there. We've treated these patients with triple-negative breast cancer with chemotherapy. Then they went on to surgery. They did not obtain a pathologic complete response. And then basically we're going to randomize them to either capecitabine, which is an oral chemotherapy and our standard at this point in that case, versus a platinum-based chemotherapy, which could be carboplatin or cisplatin. So there's also NSABP B51. This is a trial basically to look at whether we need to radiate lymph nodes if again, neoadjuvant, if she got neoadjuvant chemotherapy, she went on to surgery, no evidence of disease at that time, but she had pathologically proven, biopsy-proven lymph nodes before we did chemotherapy, and then they were negative at the time the pathologist got them after chemotherapy. Do we really need to radiate those lymph nodes now or not if they converted from positive to negative? And that's an important question to answer, which this trial should help us do. And then these are the people that helped me out. Dr. Rima Patel is my colleague in GI medical oncology, Dr. Mara Chambers in breast medical oncology, Justine Pekarsky is one of our genetic counselors, and Vera is our research nurse extraordinaire.